Hi again. This is Vivek Kulkarni, and right now we're going to be talking about renal pharmacology. The bad news about this section is that there are a lot of drugs, and it's very important to know the details of how they all work. The good news, though, is that we've already covered a lot of this material in the review of renal physiology. Just in the course of going over the nephron, we've already laid the groundwork to understand the vast majority of diuretics, and the difficulty really just comes in learning the side effects. As we move forward with diuretics, you can use this page as a reference to remember where in the nephron each drug acts and how that can be used to predict its function. Let's start off with a drug we haven't mentioned yet, mannitol. This is a sugar that is freely filtered by the glomerulus, but then not reabsorbed. The excess solute in the lumen causes an osmotic diuresis. The clinical uses for mannitol are listed here, but its use is often limited by severe side effects, including pulmonary edema, dehydration, and heart failure. Look out for mannitol being given during neurosurgical procedures to reduce ICP, or intracranial pressure. The next drug is acetazolamide, which is a carbonic anhydrase inhibitor. We've already actually mentioned this drug because it interferes with the sodium proton exchanger in the proximal tubule. It therefore causes sodium and bicarbonate loss in the urine. It's primarily used for glaucoma because it reduces aqueous humor production, and also for urinary alkalinization to prevent certain kidney stones, but it does have other uses as well listed here. The main toxicity of acetazolamide is acidosis due to the loss of bicarbonate in the urine, and it can also have other side effects that are listed here. Remember, acetazolamide causes acidosis. The next drug, furosemide, is in the class of loop diuretics and is very important in clinical medicine. As we've already talked about, it's a very powerful diuretic that works by blocking the NKCC co-transporter, leading to sodium and water loss. It's the main diuretic that's used to eliminate fluids in acute edematous states, including heart failure, cirrhosis, and nephrotic syndrome. It's also a common drug used to treat hypertension. However, it can have some serious side effects. The most obvious are hypokalemia and hypocalcemia due to the effects on the NKCC channel in the loop of Henle. It can also cause ototoxicity and drug reactions because it's a sulfa drug, as well as interstitial nephritis and gout. On the other hand, ethocrinic acid is a non-sulfa drug that works very similar to other loop diuretics. However, it can be used if a patient has a sulfa allergy. Next we have hydrochlorothiazide, the prototypical member of the class of diuretics known as thiazides, which we've already mentioned. It works by inhibiting the sodium chloride co-transporter in the distal tubule, leading to sodium and water loss. Its clinical uses are similar to loop diuretics, but the important difference in toxicity is that thiazides can actually cause hypercalcemia because they reduce calcium excretion. Other toxicities include hyperglycemia, hyperlipidemia, and hyperuricemia, as well as potassium loss. Remember, the hypers are associated with hydrochlorothiazide. All the other diuretics we've discussed lead to potassium loss, but these next ones are potassium-sparing diuretics, and they are specifically designed to avoid potassium loss. Spironolactone is unique in that it acts as a competitive antagonist for aldosterone. The other potassium-sparing drugs act directly to block sodium reabsorption in the collecting tubule. Both of these mechanisms lead to increased potassium reabsorption, thus sparing potassium. They can be used in the context of potassium depletion, but if unchecked, they can actually lead to hyperkalemia and resultant arrhythmias, which can be fatal. Also, spironolactone has some specific endocrine side effects, which are listed here. Let's go through a question to review some of these drugs. Ready? A 56-year-old man comes to your office for blood pressure follow-up. He currently takes furosemide daily. His blood pressure is 145/98 and his serum potassium is 2.9. Which of the following drugs would make the best addition to his regimen? Hydrochlorothiazide, triamterene, mannitol, or acetazolamide? If you said triamterene, you're correct. All of these agents could be helpful in lowering the patient's blood pressure, but he is also hypokalemic, and triamterene is a potassium-sparing diuretic that will increase his serum potassium at the same time as lowering his blood pressure. That pretty much sums up all the diuretics. Even though there's a lot of information here, most of it comes straight out of an understanding of the nephron, even some of the toxicities. Again, with the renal section in general, the important thing is physiology. This next fact about diuretics summarizes them all and is a good review for understanding their effects. Since we've already gone through the mechanism and effects for all the diuretics, we won't go through this table together now, but be sure to look back at this table during your studying. See if you can explain how each of these things happen based on the effects of the diuretic in the nephron. The final class of drugs that is relevant to the kidneys is the ACE inhibitors, which we've already discussed in detail. As a reminder, they function by reducing levels of angiotensin II, which has a number of distinct effects that lower blood pressure. Their primary use is for hypertension, but they are also used in heart failure because they prevent unfavorable heart remodeling, and in diabetes because they slow down chronic kidney damage. The side effects of ACE inhibitors are often the thing that prevent them from being used. The most common is cough, and that tends to be problematic. Other side effects are listed here, including a very severe side effect of angioedema. The important thing to remember is that ACE inhibitors should not be used in renal artery stenosis if it's bilateral, because they can cause hyperkalemia and potentially an increase in serum creatinine. Also, they should not be used in pregnancy because they can lead to damage to the fetal kidneys. As a side note, a newer class of drugs called angiotensin receptor blockers, or sometimes for short ARBs, can also be used in treating hypertension. Since these drugs don't increase kallikrein, they don't have the side effect of cough. So they're a great alternative for patients who can't tolerate ACE inhibitors because of the cough being a side effect. Ready for another question? An 82-year-old man with a history of multiple myocardial infarctions presents to your office with peripheral edema. Lung exam reveals bilateral crackles, and a neck exam shows distended veins. In the acute setting, which of the following drugs is most indicated? Lisinopril, furosemide, or spironolactone? In this case, the right answer is furosemide. The patient is in acute heart failure and needs a diuretic to remove the fluid. Furosemide is much stronger than spironolactone, so furosemide is the best choice. As a side note, lisinopril is useful in heart failure, but in the chronic setting to prevent ventricular remodeling. ACE inhibitors are not helpful in the acute setting when the primary goal is removal of fluid. Heart failure is discussed in greater detail in the cardiovascular section. Great job! That finishes up the renal chapter. As you can probably see, it's a lot of physiology, and it takes time and practice to master. But if you work through the cases and questions, you'll be sure to understand how the kidney works and how to apply that understanding to your exam. Happy studying!